Well, thank you again for inviting me. It's a real pleasure to be able to talk to you today about new trends in postoperative pain management. I wish I could visit you in person. Hopefully, we'll be able to do this again someday, but I really appreciate the invitation to be able to talk about some of the things that I'm passionate about and hopefully offer some advice and some suggestions on where things are going. I have no financial disclosures, and I think it goes without saying that this year has really been one of the most unique experiences of our lives as anesthesiologists. I don't think any of us could have imagined what exactly we would face in 2020 and now ongoing in 2021. But I think as we have started to become much more involved in critical care and airway management, for patients with COVID-19, we've also seen the rise and fall and rise again of different surges related to the COVID-19 pandemic. In the meantime, a lot of our regular work has had to continue. Resuming surgery. For us, at least at our hospital, we recently restarted elective surgeries that require an inpatient stay. For a while, we were only doing outpatient procedures, but I think with a lot of these resuming of activities, we've had to really think hard about how many of our protocols that we put in place continue to be applicable in the present time after COVID-19 infection. I think that pain management in particular is one area where we still have a lot of work to do. And I think when we have to consider how our protocols still apply and some of the issues related to taking care of patients, now that we are back in a regular mode of taking care of patients having surgery, we have to be able to be flexible as we were at the beginning of the pandemic, and also be very wary of some of the issues that have happened since the pandemic started. There have been a lot of predictions about the issues of the opioid crisis, as well as issues with chronic pain having gotten worse during the COVID-19 pandemic because patients have been reluctant to seek medical care. And I think that we're starting to see some of this as we started to bring patients back into the clinic, or we've expanded our video telehealth in a way where we can start to reach out and figure out where those patients are in their disease process and management and try to catch up. So I thought I would break down some of the trends and some of the themes in pain management around the time of surgery, really at three levels. So really starting first with the patient and then expanding to the health system, and then looking a little bit more broadly at the way pain management impacts society. So if we start with the patient first, I think this is really critical that we start to get much more in tune with what matters to the patient. And this photo, which I have on our VA Palo Alto anesthesiology website, is one that is always fresh on my mind when I'm trying to think about how best to manage the surgical patient, especially those who are coming for major surgery like joint replacement. I always imagine that this gentleman is walking towards the hospital, that's the front of our hospital, where he's going to have his preoperative visit, and imagine that he's going to have a total knee replacement, for example. If I tell him today what his surgical experience is going to be like and my plan for pain management, how likely is it that he's going to get that care in a few weeks or even a couple of months when he finally comes back for surgery? And I think that the way that you design your system really has to be robust enough that you can ensure that every single patient, this gentleman or the next patient who walks into the hospital for the same surgery, can expect to have a very similar approach to their pain management and surgery in a way that is universally available to all patients. I think that what we do in anesthesiology, and I think this is very true of our specialty, even though we don't call it this, is that it is personalized medicine, I think, at its finest. And I think we need to think about ways that we can personalize pain medicine and pain management around the time of surgery that doesn't take a one-size-fits-all approach, but rather using the information that we have available to us, knowing which phenotypes or which risk factors make patients at higher risk for having greater than expected postoperative pain, that we design protocols, design clinical pathways for pain management that address some of the special needs of certain parts of our population. So although we can't design an individual level pain management plan per se based on a patient's genetics, what we can do is we can take patients in whom we suspect that there may be more greater acute pain after surgery than expected, and we can approach them differently. We can prepare them differently than we would the average patient. I think part of this really has to do with getting patients the information they need at a level that they can understand. And I think this is really something that we take for granted. We often will talk to patients about procedures, like for us, at least as a regional anesthesiologist, we talk a lot about nerve blocks, and we assume that patients understand what we're saying. But it's interesting, if you actually look at what's available to patients online for regional anesthesia as a part of pain management around the time of surgery. For one, it's very interesting to me how few materials there are even available online. And then when you actually look into those materials, the reading level is much higher than you would expect those reading materials to be. Yeah, our American Medical Association recommends that all patient reading level materials be at the 6th grade level, which it's interesting if you actually look at what's out there, the reading level that our materials are written in online are actually twice that. Yeah, they're what would be expected of someone who's finished high school or even started college. I think if we get into more patient-centered outcomes, we have to understand what patients really want. So, what are our patients expecting when they have surgery? And I think that for many of our patients, especially those who have musculoskeletal surgery, joint surgery, spine surgery, they're really looking for a functional improvement, something that decreases their pain, because pain oftentimes is a driving factor for them to even seek a surgical consult, but also looking at decreasing their functional limitations, avoiding disability. Yeah, I think that these are things that patients really care about. And I think if we're going to talk specifically about regional anesthesia, this is just one set of techniques, of course, it's not all of pain management. But if we're going to say that certain regional anesthesia techniques have benefits for patients, then we have to find a way that we can design systems so that way regional anesthesia can be accessible to all patients, because it can't make a difference in our patient population unless every patient gets it. I think if we look at our reality, and this is the reality in the United States at least, much of what we talk about when we go to our specialty meetings, I go to ASRA and we talk about this nerve block versus that nerve block, we're really talking amongst ourselves. It's really experts talking amongst experts, or those passionate about regional anesthesia talking to other people passionate about regional anesthesia. If we actually look at our population-based data, however, we'll see that the use of regional anesthesia is actually very low, and even in a place that we consider highly developed. We actually use nerve blocks for knee replacement about 1 in 5 patients, which is a very, very low rate of utilization, considering that the evidence for nerve blocks in knee replacement is at least 20 years old. And I think part of the problem, at least in my opinion, is that there are just so many options. And when we look at just knee replacement as an example, when we think about how many different regional analgesic techniques we have at our disposal, they go as broadly as neuraxial techniques like epidural, which is still practiced in many places, or spinal with intrathecal opioids, to more specific unilateral blocks, plexus blocks, peripheral nerve blocks. And then they become much more narrow as you start to isolate the joint and try to minimize a lot of the side effects like motor block, to the point where even surgeon infiltration of local anesthetics, or local infiltration analgesia, the LIA technique, is commonly practiced by surgeons because it is very specific, since local anesthetic is deposited right around the knee joint itself. I think when it comes down to what do you actually have to do, I think the first thing we need to talk about is multimodal analgesia, which I'll talk about in a minute. But if you're going to consider regional analgesia as part of that multimodal regimen, then I think that it just comes down to making sure every patient has local anesthetic. Local anesthetic is a basic component of multimodal analgesia. I think at a minimum, every patient should get something that's in box A. So that something could be surgeon local infiltration, but it could also be a peripheral nerve block. I think what's in box B is an added advantage. It's actually an options package. You could look at it that way. So if you happen to have the capability where you can give the patient something in A plus something in B, then that would be better than just A alone. So an example being a femoral nerve block or adductor canal block in A plus surgeon infiltration in box B. Yeah, that combination provides much more local anesthesia coverage of the joint itself. But I think in order to get to the point where we can offer nerve blocks to every patient, we need to change the way that we teach nerve blocks. And I think that this is something that was a subject of an editorial that I wrote in Anesthesia just last year. With a couple of other colleagues from the UK. And the whole concept is that we have gotten to the point in regional anesthesia where ultrasound guidance is much more common. And because of that, we can redefine what is basic or what we consider basic nerve block training. And if we look at it that way, that regional anesthesia is not a specialty skill set only for experts, but that it's really part of anesthesiology practice that all anesthesiologists should be able to perform, then we have to start focusing on what we teach people. And when I look at our residency programs and the way that we train, it tends to be very broad, but extremely shallow, where our residents get exposure to many, many different types of blocks, but they don't do them that often. So the concept with this editorial and something that the Regional Anesthesia UK group has adopted is this idea that you should have a set of Plan A blocks, a set of blocks that you consider basic regional anesthesia for every anesthesiologist. And what you include in your Plan A list can be different from practice to practice. But we think that every anesthesiologist should be taught how to do some block for shoulder surgery. In this case, we included the interscalene. You should be able to do some block for distal upper extremity surgery. My personal favorite is the infraclavicular approach, although we listed axillary as in the Plan A list here. For hip surgery, you should know how to do a block. For knee surgery, you should know how to do a block. And for foot and ankle surgery, you should know how to do the popliteal approach to the sciatic nerve block. Now for truncal blocks, you can choose a number of different options, but for abdominal wall surgery, my personal preference is the transversus abdominis plane block or the TAP block, which is in the same family as the rectus sheath, which is actually listed in our Plan A list here. But you get the idea. I think it's really important that we, as practicing anesthesiologists, perioperative pain physicians, and teachers, start to really think about the way that we make regional anesthesia more accessible to all patients. And that's going to come through redefining the way that we teach basic regional anesthesia. Now, when we look at more broadly to the healthcare system, now clearly the healthcare systems vary widely around the world, but I think there are some very basic tenets that we can talk about. One is that, as I mentioned before, even though I'm a regional anesthesiologist and I believe in nerve blocks and I love nerve blocks and I think that they should be used for all patients, it's really just one part of perioperative pain management. Regional anesthesia is really the way that we deliver local anesthetics, but multimodal analgesia is really the overall strategy. And multimodal analgesia just means that we use two or more modalities that work differently in order to address pain. And that should not be that difficult. We know that the use of non-opioid analgesics as part of this multimodal regimen, it decreases our over-reliance on opioids, and it decreases the incidence of opioid-related side effects. When we look at the way we approach multimodal, you'll see that there are many different examples of tables that you can find in different chapters and articles, but I think we need to really start with every element, and not all of our multimodal analgesia has to be pharmacologic or interventional. Some of it is non-pharmacologic. And I think patient education, which I mentioned, is lacking. And I think that we can do a much better job of pre-assessment of patients for risk factors for greater than expected acute pain. And we can prepare patients better in terms of education and goal setting, and even using some psychological interventions like cognitive behavioral therapy. And then after surgery, I think some basic things are using cryotherapy or ice. And then in some situations, making available other non-pharmacologic modalities like acupuncture and electrical stimulation, transcutaneous electrical stimulation, for those patients who seem to benefit from it. When we start to look at some of the pharmacologic modalities, there are many, including opioids, but I think even the non-opioid modalities, I think there are several that we can choose from. You'll see here in this table as an example, I listed a couple that I considered routine unless they're contraindicated, like non-steroidal anti-inflammatory drugs or acetaminophen. There are some analgesics that I consider give only as indicated, and these are gabapentinoids, because we know that the evidence is mixed for those patients as far as routine prescribing, but they do have benefits in certain situations. Similarly, I think that NMDA antagonists also should be given as indicated, and they may be very helpful for some patients, especially those who are already on opioids chronically, or those patients who are having major surgery and you're concerned about hyperalgesia afterwards. And then local anesthetics should be routine. Yeah, but the way that we give them, as I mentioned, may be in the form of regional analgesia, or they may be in the form of local infiltration analgesia. And I think when we try to decide whether regional analgesia or new nerve blocks should be incorporated in practice, this is really something we should approach pragmatically. There are so many new blocks all the time, and every time I pick up a journal or I get an email with an e-table of contents, there's always some new block that I have to try to understand, because so many new fascial planes are discovered now that we use ultrasound for everything. If we actually look at whether or not blocks make a difference, or whether we should incorporate blocks into our practice, I think this pragmatic approach where we try to decide, well, does this new block improve outcomes compared to what I'm doing now? Or does it have a positive effect on efficiency? Or does it increase patient access to regional analgesia? Does it decrease disparities in care? I think that these are things that we should really be considering when we decide whether or not a new block is worth considering in clinical practice. And I think when we finally figure out what that multimodal regimen looks like, then we design protocols. And I think the advantage of protocols is that they force us to use essentially a checklist model. I don't really like the idea of thinking of a protocol as a recipe, because I think that most physicians tend to resist recipes because we want to be individual and we've been trained to use our brains. And I don't think a checklist really takes that away. The idea of a protocol being a checklist means that you think about all these different categories of multimodal analgesia and you decide whether or not they're appropriate for your patients. You consider indications and contraindications, but it's essentially a cognitive aid that prompts you as the physician to think about all of these things that maybe you wouldn't have necessarily remembered if you had to start from scratch every single time. And then now I think with electronic health records, I think we're able to build some of these checklists and computerized orders into our workflow, which I think also makes it much easier for us to consider these as options when we're taking care of patients. And so this is just one example. This very basic diagram just shows in a very rudimentary sense where some of the interventions we use in multimodal analgesia actually function. And this, I had the idea for this figure for this editorial that I wrote with Michael Shatman based on a stick figure that I used to draw at my patients' bedsides every time I would do acute pain rounds. And I would try to use this as a way to explain to them why we're using different modalities for pain control. And I think this is really helpful because it helps the patient, you and the patient have a shared mental model. So you're talking about the same thing. They understand, well, why are you using these other medications when opioids can be so effective? Well, with this, you can at least explain, well, opioids they are very effective analgesics, and they work in certain areas. They work at the level of the spinal cord, and they work at the level of the brain. We have other non-opioid analgesics that also work in the brain, like acetaminophen. We can use gabapentinoids. We can use ketamine or other NMDA antagonists. We have other drugs that work in the periphery, like local anesthetics or non-steroidal anti-inflammatory drugs. And we can also block pain transmission using local anesthetics. And so this is just one example of the way that I try to explain multimodality in a form and basic figure that I think patients can easily understand. When we talk to our health system administrators, this is always much more challenging for us because we tend to be more evidence-based in medicine, and we tend to talk about clinical outcomes. And for our hospital administrators, we have to be able to talk a little bit more about value, and that means looking at the basic equation of quality over cost. And I think if we look at the way that we impact healthcare at the system level, one of the ways that we've tried to do this in the United States is to really push the creation of quality measures that actually measure the way that we take care of pain care, or that we manage pain in the perioperative period. And one metric that we created, and I worked on this a couple of years ago, was multimodal pain management. So we've talked about multimodal pain management, we've talked about the evidence. This is really turning research into action. So at a national level, we created a quality metric that was approved by our Centers for Medicare and Medicaid Services. And just this past year in 2020, one upshot of 2020 is that this multimodal pain management quality measure actually became part of their national Medicare and Medicaid quality payment program. And so this is something that anesthesiologists who are doing the right thing, who are providing multimodal analgesia and decreasing the dependence on opioids, they can get credit for this when they're sending their claims, when they bill Medicare and Medicaid for services. In addition, when we're talking to administrators, I think it's important that we talk their language in terms of decreasing downstream healthcare costs. And this is a study that was performed at Stanford looking at healthcare economics. And they had found that postoperative pain trajectories, they positively predict populations at risk for coming back to the inpatient ward, getting readmitted within 30 days, or going to the ER for pain-related complications. These are the types of things that our hospital administrators want to avoid because, at least in the United States, anything that occurs within, at least for joint replacement, within 90 days is actually considered part of the cost measure for arthroplasty. And so it's important, I think, when we think how we have these conversations outside the operating room with our administrators, that we understand what matters to them. And when we look at what we offer, we know that better analgesia, better pain management, using regional anesthesia, these are things that impact the postoperative pain trajectory. They influence the acute pain experience for patients and can decrease readmissions and ER visits that way. And if you look at population-based data, this is a nice study that Stavros Mamsoudas performed looking at the premier database nationwide. When you looked at, he looked at over 1 million patients who had arthroplasty. Those patients who had nerve blocks had lower rates of complications, shorter hospital length of stay. They had decreased transfusion requirements. They had decreased incidence of ICU admission. These are all cost drivers for a hospital. And so I think that this is important information, critical data that our administrators need to know about. So let's talk finally about society. So why does society care about perioperative pain management? This, I think, is an important trend in our field because I think that what we do and the value that we bring as anesthesiologists and as pain physicians in the perioperative period has to be visible. It needs to be in the public attention in order for much of our work to be recognized. I think that many of us, as you know, have been recognized because of our response during the COVID-19 pandemic. But a lot of this great work that we do around the operating room and taking care of patients having surgery and painful procedures, and then taking care of them as chronic pain patients, does not get as much attention as our airway management and critical care skills have gotten during COVID. We know that chronic pain is a public health problem. We also know that acute pain from surgery can lead to chronic pain, and certain surgeries, I think, are much worse actors than others. Amputation has a very high rate of conversion to chronic pain. And what's even more important, if you actually look on the right side of this figure, is a certain percentage of those patients actually have disability due to pain. Um, Thoracotomy and coronary artery bypass are also high risk surgeries for chronic pain. But even some surgeries that we consider relatively minor, so outpatient breast surgeries, yeah, even inguinal hernia repair, these are surgeries that also have a not insignificant risk of chronic pain, which can still lead to disability. And I think that this is where the public needs to be aware of chronic pain being a public health problem. A common surgery for us, as even though I've given this example a couple of times, is actually knee replacement. And the reason I talk about it is that, at least in the United States, we perform at least 700,000 primary total knee replacement surgeries per year. And so if you can imagine, when something goes wrong at a high degree with those patients having that many surgeries, not only is it a public health problem, but it really increases healthcare costs. And when we look at knee replacement patients in terms of pain trajectory, it's not a small number. Almost half of those patients still have pain at 3 months, and 11% actually have neuropathic pain, which becomes chronic pain. As you can see here from their trajectory, their pain actually increases after 5 days of surgery, post-surgery, which is very different than the normal pain trajectory for patients having this operation. When you become a chronic pain patient, you use more resources. And I think this is actually well known in the United States. There's an estimate that gets thrown around that over $600 billion per year are spent on chronic pain care. And I think even if we can just directly impact that number by a little bit, if we can decrease the percent of patients who go on to have chronic pain by just a small amount, that actually is cost savings for the United States healthcare system. And I think that the opioid epidemic is something that we have spent a lot of attention and time and attention on in the United States and in North America, because we, as you can see from this worldwide graph, that there's a heavy concentration of opioid-related overdoses and deaths in North America. But it's interesting because what we've seen more recently has been a curbing of opioid prescribing. There are other sources of opioids and opioid overdose deaths, which I'll talk about in a minute. But we've actually impacted the prescribing rates through various mechanisms. Now, even though you don't see the Philippines highlighted on that previous graph, don't worry, because this opioid epidemic is spreading around. And I found this really interesting. I saw this on Twitter not too long ago. There's this article that was actually published by Dr. Furlan. And it describes a opioid, a pharmaceutical company called Mundipharma. And I'd never heard of Mundipharma before, but it turns out that Mundipharma is actually owned and started by the Sackler family. The Sackler family is the same family that started Purdue Pharmaceuticals, which created OxyContin. And so this quote I pulled from this article: the pharmaceutical companies like Mundipharma have expanded marketing of opioids for chronic pain to other countries around the world, since certain countries like ours have really cracked down on the prescribing of opioids, and especially long-acting opioids. So one project that I worked on just in this last year was this international consensus statement on preventing opioid-related harm. And if you scan the QR code, you'll be able to pull up the article, which is available free from Anesthesia, and has a list of a number of modifiable factors and recommendations that we provided. And you'll see here that many of these, I think, are somewhat common sense and generally accepted. But I think it is important that we talk about these things. I think when we're talking about trends in pain management around the time of surgery, we have to talk about preoperative preparation. We have to make sure that we prepare patients psychologically, that we assess them for risk factors, we set expectations. We want to make sure that we identify abnormal pain trajectories early in the postoperative period, just like I alluded to with knee replacement patients. We want to make sure that we avoid the over-reliance on opioids, that we avoid long-acting opioids, because it's very difficult to get patients to taper and cease long-acting opioids. And we have to make sure that we use the right drug at the right time. And so we try to avoid compound drugs like acetaminophen with an opioid, so that we can separate them and make sure patients are maximizing their non-opioid analgesics. Other things that are important are really preparing patients well for discharge. So this means coming up with a method to limit the number of opioid pills or the opioid dosage that patients go home with after surgery. We want to make sure that we give them very, very specific instructions on how to taper their opioids. And then when they're done taking these potent pain medications, there has to be a safe way for them to dispose of them, whether we have take back events or they can mail them back. These are the kinds of things that we have to make sure that patients are doing, so that way those opioids don't accidentally fall into the wrong hands and lead to overdose and death. In the United States, as I alluded to, we've actually curbed the overprescribing of prescription opioids. But that doesn't mean that we still don't have an opioid epidemic. And we know that the use of prescription drugs has reinvigorated the heroin epidemic and the epidemic of synthetic opioids like fentanyl. As a nation, the United States has approached this multiple ways. And I've been working with our National Academy of Medicine's Opioid Collaborative. I work in two of the groups, the pain management guidelines work group and the research and development work group. And then our American Society of Anesthesiologists has been very active in collaborating with surgical societies like the Pain Relief Toolkit, which we created with the American Academy of Orthopedic Surgeons. We've done joint guidelines with the Association of Breast Surgeons and Head and Neck Surgeons. And we've worked with health systems like the Premier Innovation Network, which invited the ASA to provide education and coaching for many of these hospital facilities in implementing opioid stewardship programs, multimodal analgesia, and safe opioid prescribing practices. And I think some things that we can do at the local level can't be neglected. And sometimes we look at the opioid problem as being too big. But I think that sometimes you have to break it down into smaller problems and then try something. Because I think that one of the things that we are very good at doing as anesthesiologists is troubleshooting and trying new things. And I think that we can apply this to our systems. This is an example of something that we did as an improvement project, just trying to create a basic tool for patient-specific opioid prescribing and with very explicit instructions on how to taper their opioids. And it was a relatively simple concept. We've worked for years on establishing a robust multimodal analgesic regimen for all of our total joint arthroplasty patients. We also have, we utilize regular regional analgesia. We have regular non-opioid prescribing. We have regimented order sets with patient education. We also have a validated assessment tool for pain scores that really drives the prescribing of their as-needed breakthrough medications. And so by doing this, what we did is we created a tool that was based on the patient's prior 24-hour use. So they use that as the high daily dosage for their oxycodone prescription. Then every third day, they have very specific instructions, as you can see from the table, where they decrease their dosage and number of pills over time. And so basically, like any patient, say, for example, as I'll give the 30 milligram example, if a patient, the prior 24 hours used 30 milligrams of oxycodone after knee replacement, then that row becomes their prescription. So for the first 2 days, they're given the prescription for oxycodone with 5 milligram tablets you can take up to 6 times daily. On the next 2 days, they can take it up to 4 times daily. On the next 2 days, on days 5 and 6, they can take it 2 times daily. And the total number of pills they go home with is based on that taper is 24 pills, and that's it. When we looked at our data, and you can see from the box plot that we decreased our prescribing of opioids by 2/3 which was a massive decrease compared to our state before we introduced this tool. And we did not see an increase in requests for refills. We didn't see an increase in readmissions. We didn't see an increase in ER visits, suggesting that our pain management was just as good as it was before, but we've decreased the amount of opioid pills out in the public, where they could fall into the wrong hands. And I think that there are a lot of opportunities for us to really innovate in pain medicine. I think we need to look at pain as a continuum, starting from before surgery when patients are scheduled all the way through their full recovery. And when we look at where the gap is located, at least in our system in the United States, we found that this transition, from the time when patients leave the hospital to the time that they're fully recovered and back under the care of the primary care physician, is a real gap in care. And that's typically when those patients who develop chronic pain or neuropathic pain, like the knee replacement patient population, they declare themselves on post-op day 5. Who's caring for them at that time is actually an important question. And we realize they're still under the care of the surgeon, but realistically, they're not getting the pain care that they need. And so what we did is we actually created a transitional pain program. This was inspired by Dr. Hans Clark's program at the Toronto General Hospital. And what we've had to do, as you can imagine, during this era of COVID-19, is really expand our use of video telehealth. And so we still have inpatient clinic visits, but now we do a lot of our clinic consults on these patients who are already at home after hospital discharge via video telehealth. And I think what's important is that this is a way for us to maintain surveillance for patients who may be on an abnormal trajectory of pain resolution. We can identify those patients who are having difficulty with weaning their opioids. And then we can also use it as a source for expert consultation when we have patients scheduled for surgery who are highly complex. And this is an example of an article that our director, Dr. Kyle Harrison, put together, where those patients who are on opioid maintenance therapy or treatment for opioid use disorder, they are automatic consults to our transitional pain program because we know that they're going to be more difficult to manage perioperatively. The other thing that I think our transitional pain clinic can offer now are just newer interventions. Now, I'm not trying to say that all pain management is interventional, but it is helpful to have new tools available to offer patients when it's applicable. We've successfully used percutaneous peripheral nerve stimulation as a modality, a neuromodulation modality in that transitional period. Here in the United States, we have a stimulator lead that's approved for 60 days of use. And so that may be one non-opioid, non-local anesthetic form of regional analgesia that can be extended much further into the postoperative period for patients who have greater than expected pain. We also have available to us cryoanalgesia. And cryoanalgesia or cryoablation is not a new modality for pain physicians at all. It's actually an old modality. But this also may have some use, especially for some patients who have persistent pain. And this has been used now for patients with post-thoracotomy pain and patients with rib fracture pain successfully in clinical practice. So in summary, hopefully I've been able to show you some of the trends in postoperative pain management from the individual level, all the way to the society level. I think that regional anesthesia, can stay relevant in much of what we do as long as we try to figure out how best to train anesthesiologists in basic regional anesthesia and also figure out how it fits into protocols at the system level, and then also try to identify ways that regional anesthesia can morph into regional analgesia that's a little bit longer lasting and hopefully can affect the trajectory of patients and prevent the incidence of chronic pain. So thank you very much again. I appreciate your attention and the opportunity to speak with you.